Good morning. I'm going to go ahead and share my slides. My name is Dr. Claire Wright. I'm an assistant professor of ophthalmology here at the University of Tennessee in Memphis. I'm going to be lecturing you all on the diagnosis and management of low tension glaucoma. So I received a number of really great questions, which I hope most will be answered by this lecture, and I will definitely take questions at the end through the chat feature. So no financial disclosures here. Our objectives will be to discuss the epidemiology and clinical features of low tension glaucoma, or LTG, review the diagnostic workup and differential diagnosis for LTG, and detail management strategies for LTG and differentiating how these may differ from primary open angle glaucoma management. So I've got a couple poll questions to start, and these will be the same poll questions at the end for review. So our first question: low tension glaucoma is the most common form of open angle glaucoma in which of the following ethnicities? A, North American, B, Southern Indian, C, South African, or D, Japanese? I'm going to give you all about 30 seconds to answer this. Again, question is, low tension glaucoma is the most common form of open angle glaucoma in which of the following ethnicities? North American, Southern Indian, South African, or Japanese? All right, so a pretty good spread of responses. So hopefully this question will be answered in this lecture. Next question: all of the following are considered risk factors for low tension glaucoma or associations, except A, anemia, B, hypertension, C, obstructive sleep apnea, or D, Raynaud's phenomenon. Again, question is, all of the following are considered risk factors or associations, and we'll get into this, for low tension glaucoma, except anemia, hypertension, obstructive sleep apnea, or Raynaud's phenomenon. All right, so again, pretty good spread, kind of split between anemia and hypertension. Next question: all of the following are classic clinical features of low tension glaucoma, except A, disc hemorrhages, B, nasal step, C, focal disc notching, or D, paracentral scotoma. Again, the question is, all of the following are classic clinical features of low tension glaucoma, except disc hemorrhages, nasal step, focal disc notching, or paracentral scotoma. All right, pretty good mix of responses. Fourth question: according to the collaborative normal tension glaucoma study, which of the following is the target IOP reduction from baseline for patients with low tension glaucoma? A, 10%, B, 25%, C, 30%, or D, 40%? Again, the question is, according to the collaborative normal tension glaucoma study, which of the following is the target IOP reduction from baseline for patients with low tension glaucoma? 10%, 25%, 30%, or 40%? All right, good, pretty good spread. So this is exciting. Hopefully we'll see kind of more uniformity with our follow-up questions. Last question: which of the following topical glaucoma medications should be avoided, if possible, in the management of low tension glaucoma? A, timolol, B, latanoprost, C, brimonidine, or D, dorzolamide? The question again is, which of the following topical glaucoma medications should be avoided, if possible, in the management of low tension glaucoma? Timolol, latanoprost, brimonidine, or dorzolamide? Okay, pretty split responses. So I kind of like seeing this because then it gives me an opportunity to hopefully educate our audience. So we're going to go on and move on to the lecture portion. So a little bit about the background of low tension glaucoma, the historical perspective. This is also known as normal tension glaucoma. So I'll primarily use the term low tension glaucoma, but essentially they're the same. The older terminology for LTG, or low tension glaucoma, in the literature included soft glaucoma, pseudoglaucoma, and glaucoma without hypertension. In one of the first reports about low tension glaucoma, written by von Graefe in 1857, he reported cases of disc cupping and pallor at normal intraocular pressures. And interestingly, in kind of literature review of low tension glaucoma, there really was an increase in frequency of reporting after the invention of the Schiot's tonometer in 1905. And that just makes sense because we're getting more reliable intraocular pressure measurements. In 1931, Dr. Picard delineated several cases of normal tension or low tension glaucoma and recognized it as a separate entity from glaucoma with elevated intraocular pressure. Now, how are we, defining low tension glaucoma? Well, again, this is also known as normal tension glaucoma. And this is more or less defined as optic neuropathy with associated nerve fiber layer thinning and eventual visual field defects that occurs at statistically normal intraocular pressures. So, as we counsel all our patients, normal pressures 10 to 21 millimeters of mercury, any glaucoma that is occurring within that normal range of pressure, it can be defined as normal tension or low tension glaucoma. But you do have to keep in mind factors that influence intraocular pressure, such as diurnal fluctuation, corneal factors. And so make sure you're not excluding primary open angle glaucoma given these factors. And so it's also with this particular disease, it's very important to keep in mind that intraocular pressure is just one of a myriad of risk factors that you can modulate to prevent progression. And we will get into that in this lecture. And so let's talk about the epidemiology of low tension glaucoma. So this incidence varies by region, but there is a particularly high prevalence in Asian populations. And so looking in the literature, you get quite a wide range of spread depending on the ethnicity, with quite a high prevalence in the Japanese population. So of all open angle glaucoma patients, low tension glaucoma makes up, according to literature, 92.3% of of open angle glaucoma patients in Japan, 82% of those patients in southern India, about 57% in South Africa, and then more like 1/3 of patients in the United States. And with regard to genetics, approximately 2% of cases are inherited, typically autosomal dominant. And there may be a link between low tension glaucoma and dementia, according to some studies, particularly vascular dementia. And so what's the etiology of low tension glaucoma? Well, it's not fully understood, but there are many hypotheses. Some postulate that it's due to vascular dysregulation. Others think that there's a contribution due to reduction of ocular perfusion pressure. And I had to look this up. Ocular perfusion pressure is mean arterial pressure minus intraocular pressure. Others think there's contributions from blood dyscrasias, anemia, coagulability issues, et cetera. And then still others think that there perhaps is a component of impaired CSF or CSF circulation or low retrobulbar CSF pressure contributing. So you do have to think about in these patients, well, what are other factors that may be contributing to optic neuropathy in addition to IOP, which could be lowered? So specifically asking and inquiring about ischemia, vasospasm, autoimmune diseases, and coagulopathies. So diving into more of these systemic risk factors or associations, there seems to be much emphasis on the presence of whether there's vascular disease or not in these patients, including a history of diabetes, stroke, hypotension, obstructive sleep apnea, vasospasm, including migraine and Raynaud's phenomenon, or a primary vascular regulation issue. Some define this as Flommer syndrome, which results in impairment or decrease in ocular blood flow autoregulation, and as I mentioned, vascular dementia. So these are across various studies found to be associations or potential risk factors that you could modulate as a provider in patients with low tension glaucoma. So I wanted to actually draw particular attention to that hypotension as a risk factor. A huge study came out in 2016, 2017, called the SPRINT study, which found that for patients with hypertension who underwent intense blood pressure control, so target systolic blood pressure under 120, those patients fared much better with regards to fatal and non-fatal major cardiac events with regards as compared with patients who had standard blood pressure control. So this resulted in a big paradigm shift with regards to the definition of hypertension here in the United States from both the American College of Cardiology and the American Heart Association. This occurred fairly recently, where now elevated blood pressure is defined as anything over 120 systolic and 80 diastolic. And so when I was a medical student 10 plus years ago, it was actually 140 over 90. And so now, in one review article I read, the authors advised its readers to, hey, we better watch for iatrogenic hypotension with subsequent nocturnal hypotension, which may result in concordant rise in the diagnosis and incidence prevalence of low tension glaucoma. So I thought this was very interesting, change in development and change in definitions of a very commonly diagnosed condition, hypertension. So let's talk about briefly the differential diagnosis of low tension glaucoma. So general kind of pillars, the differential diagnoses, think glaucomatous optic neuropathy versus non-glaucomatous optic neuropathy. So under the umbrella of glaucomatous, you can think primary open angle glaucoma, and perhaps you're just not catching the high pressure readings because you're seeing them, in the afternoon, or they've got thin corneas, so you're underestimating pressures. These patients, other potential diagnoses can include traumatic glaucoma or steroid-induced glaucoma. And diagnoses to think of in these patients that are non-glaucomatous causes of optic neuropathy can include infectious, nutritional, compressive, and vascular etiologies. So namely an infectious would be syphilis, B12 deficiency would be under the nutritional cause, compressive you think CNS lesion, namely pituitary adenoma meningioma, and then vascular reasons would be a non-arteritic ischemic optic neuropathy and giant cell arteritis. So always good in a new patient presentation to think, okay, what's my differential diagnosis so I don't miss anything, even though I may think, okay, this is most likely low tension glaucoma. So what's going to be in the patient history, or what are some things we should inquire about to our patients who present with what is thought to be low tension glaucoma? So, you should elicit a history based on your differential diagnosis and so diagnoses. And so you ought to inquire about, in these patients, about any potential history of the following, and we've discussed this already before: vascular and or vasospastic diseases, and as with all glaucoma patients, ask about a history of ocular trauma, previous procedures, including refractive surgery, steroid use, family history of glaucoma, and blindness. Other general information, ask about diet. If you're thinking nutritional deficiency, you ought to inquire about any history of sexually transmitted diseases. If you're thinking syphilis is a potential differential diagnosis, and then do obtain a concise review of systems, inquiring specifically about neurological symptoms if you're concerned about a CNS lesion, and giant cell arteritis symptoms. So what's our clinical workup? This pertains to really any glaucoma patient, in my opinion, but with kind of tailored details for a low tension glaucoma patient. Of course, you're obtaining visual acuity, intraocular pressure, pupil exam, refraction, anterior segment exam, making sure you perform gonioscopy, and these patients will have open angles, and then a posterior segment exam with careful examination of the optic nerve. And low tension glaucoma can be characterized or classically seen to have focal rim notching, disc hemorrhages or Drance hemorrhages, and or peripapillary atrophy. So what are some clinical tests that we can obtain in clinic that may help our workup of these patients? I obtain pachymetry readings in all of my glaucoma patients, so I know approximately how accurate our pressure readings are. It's helpful to obtain, of course, automated perimetry. I typically, in our practice here, we get home free visual fields. You can also get an octopus perimeter, virtual visual fields, etc. And it's important to note you actually may need to follow up with a 10-2 visual field, as fixation loss tends to be involved early in these patients. So that's an important note. I recommend, getting a formal assessment of the retinal nerve fiber layer, and you can kind of pay particular attention to the macular retinal nerve fiber layer in early or late disease. And this nerve fiber layer thinning, as with all glaucoma patients, should correspond with visual field loss. And then you can also obtain disc photos. So getting specifically into automated perimetry, low tension glaucoma patients, their visual field loss is characterized by deep and focal loss that is closer to fixation earlier in the disease compared with primary open angle glaucoma patients. So specifically, they can have paracentral or central scotoma versus the nasal step, which then can progress to arcuate scotoma in primary open angle glaucoma. And as I mentioned in the last slide, these low tension glaucoma patients may require either 24-2C, which includes a couple extra foveal points, or 10-2 to further characterize the fixation involving visual field defects that may be seen just a little bit on the 24-2 or 30-2. So some images to illustrate the paracentral scotoma that characterizes low tension glaucoma, as opposed to the nasal step, which can then progress to an arcuate scotoma in primary open angle glaucoma. So what are some additional workups that you may want to consider in low tension glaucoma patients? Well, this workup ought to be reserved for cases with a high index of suspicion for a non-glaucomatous process. So you can then think about the, nutritional, metabolic, infectious optic neuropathies. But many times you have clues for these in the history, review of systems, or exam. And so you're going to pick up on a history of exposures, limited diet, systemic symptoms, which can include neurological symptoms, et cetera. And again, getting into the details, if you're thinking of a CNS lesion or a compressive cause of optic neuropathy, many times these patients can have some neurological symptoms. And you're also going to be, a big red flag also is non-corresponding clinical testing. And so by that, I mean visual field loss and disc pallor out of proportion to disc cupping and nerve fiber layer thinning. So you should always have everything should match up on your exam of patients. So you should see disc cupping with corresponding nerve fiber layer thinning that then corresponds to a visual field defect. That should all line up. And if it doesn't, if there's a mismatch, then you should think about potential CNS lesion. Other red flags, significant asymmetry of the optic nerve appearance with regards to cupping, pallor, color vision loss, or vertical visual field defects. So how do we manage low tension glaucoma? Well, as with all glaucoma, the intraocular pressure remains the most modifiable risk factor in disease management. And so you can lower the pressure, as with primary open angle glaucoma, with drops, laser, and surgery. But in addition to pressure control, you really have to think about mitigation of other risk factors. And so you think about, well, what are these other potential comorbidities that the patient may have that we can work with, say, the primary care doctor on or other specialists on. And so that can include blood pressure control, correction of anemia, treatment of coagulopathies, et cetera. So I wanted to use this time now to talk about a very important study in normal tension and low tension glaucoma management, which is the collaborative normal tension glaucoma study. So in this study, patients were randomized to either observation or treatment of their diagnosed normal tension glaucoma, and treatment could consist of any combination of drops, laser, or surgery at the surgeon's discretion. The target for IOP reduction in the treatment group was 30% from baseline. These patients in their treatment, they were avoided, beta blockers and alpha adrenergic agonists were avoided. And important to note, the observation arm could be treated if they demonstrated evidence of deterioration. So the results of this study, the rate of progression in these normal tension glaucoma patients was reduced with treatment over 5 years. It seems logical. So in the treatment group, 12% progressed at 5 years versus 35% in the observation group. What's interesting is actually 65% of patients in the observation group did not progress. curious. And so makes you wonder if potentially those patients had some of those other comorbidities contributing in a more important way. And so this study established that the goal of 30% IOP reduction from baseline as target for patients with normal or low tension glaucoma. So let's get into more of the pharmacotherapy of low tension glaucoma management. And so, it's similar to primary open angle glaucoma management, but there are some important caveats. In various studies, brimonidine has been found to demonstrate a neuroprotective effect in these patients. And beta blockers has been found to actually reduce optic nerve head perfusion, and therefore, tends to be avoided in the management of these patients. Some studies have also found that the newer class of agents, Rho kinase inhibitors, may actually enhance optic nerve head perfusion through that nitric oxide pathway. And this one study I found by Chiara et al. 2018 found that there was actually, interestingly, an enhanced parapapillary vessel density seen on OCT angiography with the use of this Rho kinase inhibitor, rapacidil. Getting into the more details about brimonidine versus timolol, the low pressure glaucoma study actually compared the use of these two medications in the management of low tension glaucoma. And the study found that the two medications had similar pressure lowering effects, but brimonidine use of brimonidine resulted in less visual field progression than timolol. There is talk that potentially calcium channel blockers, systemic calcium channel blockers, may enhance vascular tone in these patients, particularly those with an underlying history of vasospasm, but larger clinical trials are lacking. So let's get into low tension glaucoma management with laser. So similar to primary open angle glaucoma, you can offer these patients selective laser trabeculoplasty, micropulse, cyclodestructive procedures. Now, SLT has been found, in this one particular study in 2015, that you can get a reduction, 15% reduction from baseline, modest, but still only half of what is recommended according to the collaborative normal tension glaucoma study. But you can get actually a big reduction in the number of drops. So a modest effect with SLT. Micropulse laser in the study in 2020 found that there was 20% reduction from baseline, also modest, still not 30%, which is recommended. And as with primary open angle glaucoma, cyclodestructive procedures, i.e. cyclophotocoagulation, usually is reserved for refractory cases due to potential side effects of hypotony, severe inflammation, vision loss, etc. So, before we get into the surgical management, I thought it would be interesting to bring up some of our medical history. And I found this report by Dr. Bloomfield in 1953, where he reported the surgical results for low tension glaucoma, namely these mostly unused procedures, which included the Elliott trephination, iridonclesis, cyclodialysis, and modified Lagrange operation. His report wasn't great, and he was quoted in this report to find that surgery is not significantly helpful in preventing further deterioration of visual function in that condition. A little depressing. However, a lot has changed since 1953. We have many more sophisticated techniques available today, and I'll be talking about those now. And so surgical options for low tension glaucoma can include cataract extraction with intraocular lens implantation and minimally invasive glaucoma surgeries, MIGS, tube shunts, and blood forming procedures, namely trabeculectomy with mitomycin, express mini glaucoma shunt, and the Zen gel stent. So looking at cataract extraction with MIGS, you got to keep in mind across, every time you're seeing these patients need a low pressure goal. They've already come in, their baseline pressure is normal or low. And then you're trying to lower it 30%. So many of these patients need sub 12, sub 10 pressure goals. And so it's actually difficult to obtain these pressure goals below what we know to be episcleral venous pressure, which is approximately 8 to 10 millimeters of mercury, and due to also the vascular resistance distal to collector channels. And so this is difficult to obtain with cataract surgery and MIGS or angle-based MIGS alone. But, there's a role potentially for these procedures at lowering the pressure, postoperatively and reducing the drop burden. So I found this review article, which was a meta-analysis of MIGS used for normal tension glaucoma management. They found reports on the use of iStent inject, Hydrus, the Cahook dual blade, and the trabectome with or without concomitant cataract extraction with lens implantation. And this meta-analysis found that all of these procedures demonstrated significant pressure lowering and reduction in the use of anti-glaucoma medications across all time points up to 36 months post-operative. So there can be a role, but at lowering the pressure some and reducing the number of drops. So that it's an available option. So I do now want to talk about the use of trabeculectomy and tube shunts for these patients. So a word on tube shunts first. We know based on the 5-year, many of these studies comparing Ahmed versus Beerveld, that the mean pressure obtained by these is going to be in the low to mid-teens with or without drops. So if you think about your patient who's coming in with low tension glaucoma, average pressure mid-teens, you need to lower that 30%. So to pressure of 10, you're probably not going to get there just with a tube shunt. And so, these are certainly appropriate options if you've already tried a blood forming procedure and that's failed. And, that's an option. But as a primary procedure, you maybe ought to consider first blood forming procedures. And so by that, I mean trabeculectomy with mitomycin C, Zen, or express mini glaucoma shunt. So kind of moving on to trabeculectomy with mitomycin C in the collaborative normal tension glaucoma study, looking back at that, about 43% of these patients ended up needing a filtering surgery to maintain that 30% reduction from baseline. However, with this TRAB, there is a very narrow margin of error between what is considered therapeutic intraocular pressure and hypotony. If you've got a patient coming in again, pressure 15, you need to lower that 30%, so to 10. What's that line between therapeutic pressure and clinically significant hypotony? It's pretty narrow, anywhere between 5 to 10, 8 to 10. That's a pretty narrow window. So what are some alternatives to trabeculectomy that maybe are a little bit less risking hypotony? Well, you can consider the Zen gel stent or the express mini glaucoma shunt. I found a report from 2020 that found that the pressure reduction for a Zen gel stent, that managed to reduce the mean IOP from approximately 16.6 to 11.6. So pretty good. So you don't usually risk as much hypotony with the Zen gel stent as opposed to trabeculectomy. So what are some other therapies that, we can consider offering these patients with low tension glaucoma? Well, I'll just, basically say that there's less data on the following recommendations. And really, as with primary open angle glaucoma, the pillar of treatment is pressure lowering, but other considerations you can make to mitigate glaucomatous progression or to offer patients who seem to be progressing at physiologically great target pressures would be to offer careful monitoring of blood pressure with special attention to avoid nocturnal hypotension. Nocturnal hypotension can reduce perfusion of the optic nerve head and can run the risk of visual field progression. And so this translates is I tell my patients, hey, if you don't already, keep a blood pressure log, checking morning and evening blood pressures, and try to avoid nighttime dosing of blood pressure medicines. If it's once a day dosing, I usually get in touch with their primary care doctor to say, hey, can we consider morning dosing instead of evening dosing to mitigate that risk of nocturnal hypotension? And usually they're quite accommodating. Other, kind of soft recommendations can include aerobic exercise with care to avoid prolonged inversions, like in yoga, downward dog. Supplementation, there's some data on ginkgo biloba, which in some studies has been found to enhance the blood flow velocity and reduce vascular resistance versus placebo. However, some side effects can include bleeding and seizures. So, and also these supplements, at least in the United States, are not regulated by the FDA. So you could get a bottle of ginkgo biloba from one company and just have it be different, whole different can of worms than another bottle of ginkgo biloba. So I'm very hesitant with recommendations of supplementation in the use of glaucoma. There's another antioxidant called resveratrol, which is found in skin of red grapes and red wine, which has some antioxidant features. And another option would be to consider vitamin B12 supplementation, particularly those who have sub-optimal levels. And then mindfulness and meditation has been, there's been large trials, primarily, I believe, primary open angle glaucoma management that has been demonstrated to show that there's reduced visual field progression for those who have a regular meditation mindfulness practice as opposed to those with not. So I think where I practice in the Mid-South, I have many patients who are practicing Christians, or religion's a very important part of their life. And so I do bring this up. And, I think it's very sometimes validating for them to see that there's not just spiritual benefits of prayer, meditation, but also potentially physical benefits. So I do want to take this time now. We're kind of moving towards the end of the lecture. I want to have this grid here to kind of compare, contrast low tension glaucoma with primary open angle glaucoma. So the chief affected demographic we can see in low tension glaucoma, as we reviewed, primarily Asian populations with particular high prevalence in the Japanese population. Compare this or contrast this with primary open angle glaucoma, where it's very high incidence in Afro-Caribbean populations. Visual field findings in low tension glaucoma, as we reviewed, you can get early involvement of paracentral central area on the visual field, and you contrast this with the classic early nasal step in primary open angle glaucoma, which then can progress to an arcuate kind of wing scotoma. Pressure reduction goal in low tension glaucoma, as reviewed multiple times, 30% reduction from baseline, according to that collaborative normal tension glaucoma study, which then may entail early blood forming procedures. And then other studies in primary open angle glaucoma varies, but what I see commonly is about 25% reduction from baseline. Clinical features of low tension glaucoma, as we've discussed, classically, you can see frequent disc hemorrhages, focal notching of the optic nerve. And then you can also, many times you have to inquire about this known history of vascular and vasospastic conditions. And then, primary open angle glaucoma, as we know, disc appearance, just generalized versus vertical cupping. And so it is not as much kind of focal regions classically. So I'm finished with the lecture portion. Now what I'm going to do is go back to those initial 5 polling questions to review to see if hopefully we've acquired some new knowledge or had a good review. And so we'll go ahead and kick off these polling questions again. So question number 1, low tension glaucoma is the most common form of open angle glaucoma in which of the following ethnicities? A, North American, B, Southern Indian, C, South African, or D, Japanese? Again, low tension glaucoma is the most common form of open angle glaucoma in which of the following ethnicities? North American, Southern Indian, South African, or Japanese? All right, 84% of you answered correctly, and it's Japanese. Good. Second question, all of the following are considered risk factors or associations for low tension glaucoma except A, anemia, B, hypertension, C, obstructive sleep apnea, or D, Raynaud's? Again, the question is, all of the following are considered risk factors for low tension glaucoma except A, anemia, B, hypertension, C, obstructive sleep apnea, or D, Raynaud's. Okay, good. So about 2/3 of you answered correctly. The answer is hypertension. So actually what is considered a risk factor or association is hypotension, low blood pressure. And that is thought to be due to hypoperfusion of the optic nerve head. Now, kind of as a corollary, you should ask about hypertension in these patients, and then specifically if their dosing of their blood pressure medicines, because that nighttime dosing can cause nocturnal hypotension. But in this, the answer to this question is B, because it's primarily hypotension, low blood pressure. That's considered a risk factor or association for patients with low tension glaucoma. So good. Third question, all of the following are classic clinical features of low tension glaucoma except A, disc hemorrhages, B, nasal step, C, focal disc notching, or D, paracentral scotoma. All of the following are classic clinical features of low tension glaucoma except A, disc hemorrhages, B, nasal step, C, focal disc notching, or D, paracentral scotoma. All right, good. So 76% of you answer correctly. The answer is nasal step. So nasal step, the reason why that's not the answer is that is classically the early visual field finding on primary open angle glaucoma, which then can progress to an arcuate scotoma as the disease progresses. The other features, disc hemorrhages, focal disc notching, early paracentral scotoma are more classic for low tension glaucoma. Good. So our fourth question now, according to the collaborative normal tension glaucoma study, which of the following is the target intraocular pressure reduction from baseline for patients with low tension glaucoma? Again, according to the collaborative normal tension glaucoma study, which of the following is the target IOP reduction from baseline for patients with low tension glaucoma? All right, good. So 89% of you nailed it. The answer is 30%. So you think about this, it actually kind of makes sense. These patients are coming in with already normal to kind of low normal pressures. You want to get that lower, you're going to need a lower pressure goal compared to what they're coming in with at baseline. So 30% target IOP reduction from baseline is the correct answer as delineated by the collaborative normal tension glaucoma study. Good. Last question. Which of the following topical glaucoma medications should be avoided if possible in the management of low tension glaucoma? A, timolol, B, latanoprost, C, brimonidine, or D, dorzolamide? Again, the question is, which of the following topical glaucoma medications should be avoided if possible in the management of low tension glaucoma? Timolol, latanoprost, brimonidine, or dorzolamide? Great. So about 3/4 of you answered correctly. The correct answer is timolol. So in various studies of treatment of patients with low tension glaucoma studies, low tension glaucoma, timolol has been found to, especially when compared with brimonidine, actually result in visual field progression despite adequate pressure lowering. And so that's postulated to potentially be due to contributions to blood pressure, reduction in ocular perfusion pressure. So my first line treatment for patients, topically for patients with low tension glaucoma, it tends to be either brimonidine or latanoprost, followed by dorzolamide, and I try to avoid timolol. Okay, so let's review some lecture takeaways. And again, I'm a broken record, but we've reviewed all these things, just takeaway points. So low tension glaucoma can be associated with and exacerbated by certain systemic conditions, namely hypotension, anemia, obstructive sleep apnea, Raynaud's, or migraine. And so inquire about as to whether a patient has these conditions and work with a primary care doctor on optimizing those in as part of the management for low tension glaucoma. Classically, low tension glaucoma demonstrates disc notching, or excuse me, disc hemorrhages, focal disc notching, and early paracentral scotomas. And this contrasts with the earlier nasal step, which then can progress to an arcuate scotoma in primary open angle glaucoma. With regards to pressure reduction goal, aim for 30% IOP reduction from baseline in low tension glaucoma. Again, this is from the collaborative normal tension glaucoma study. Those patients are less likely to progress than at that target pressure. With regards to medication choice, brimonidine may impart neuroprotective benefits, and timolol may be associated with visual field progression. So that's why I generally try to avoid topical beta blockers in these patients. And whereas in primary open angle glaucoma management, many times brimonidine is more of a second or third choice. In low tension glaucoma management, it moves up higher on the list because of its neuroprotective features. Now there are numerous surgical options available in the management for low tension glaucoma, but you have to keep in mind that low pressure goal. And so these patients may end up requiring bleb forming procedures such as trabeculectomy with mitomycin C, Zen gel stents, and or express mini glaucoma valve placement. These are my sources, and so we are all done. It's about 7:43 my time. We've got a fair amount of time for questions. I'm going to hit stop share. Thank you for your attention. I'm going to go ahead and look at the Q&A and hopefully get some of these answers for you guys. So first question, when do we diagnose low tension glaucoma in those with thin central corneal thickness? And so that's a great question. So with regards to, obtaining pressure in patients with thin central corneas, you are underestimating your pressure. There's been no, verified conversion factor. Some people propose, charts say if central corneal thickness is this measurement, pressure translates to this measurement. But so you get a gestalt if the central corneal is thin. Okay, I'm underestimating pressure. So good question. So keeping in mind their thin corneas, so that you're underestimating pressures. I think that if you're still, if patient still doesn't have a pressure higher than mid to high teens, that could still be low tension glaucoma. So it's a little bit, where's the line between low tension glaucoma and POAG? Good question. It could be a little bit, there's a lot of gray areas. And so if I'm not sure, I still inquire as to those potential risk factors of low tension and normal tension glaucoma, and still shoot to lower the pressure more like 30% as opposed to 25%. But there's not a cut and dry answer here. There's a lot of gray areas. Okay. I'm not sure what this next one, GCC, I'm not sure what that stands for. So screening tests for normal tension glaucoma. Well, it's going to be pretty much have the patient come in, do an exam, check the pressure, get the pachymetry, gonioscopy, and then do the visual fields and RNFL screening. And so, ganglion cell complex, thank you. I figured that's what it was, but I wanted to verify. So yeah, retinal nerve fiber layer assessment can be helpful in determining if there's nerve fiber layer thinning. But but that should correspond then with visual field defects. So you can use that as a diagnosis of low tension glaucoma. So I guess you could use that to screen as well. So yeah, I would say so. Is there any possibility of unilateral low tension glaucoma? You can get asymmetric disease in many of these glaucomatous optic neuropathies. And so, to answer your question, I've seen it before. Yes, I still ask about those, history and potential comorbidities, and still shoot for 30% reduction of pressure in the affected eye, and just continue to watch the fellow eye closely. What lab test do you order and why? So if we order lab tests for these patients, it's because I'm highly suspicious for non-glaucomatous optic neuropathies. And so those tests that I order can include vitamin B12, RPR, FTA, ABS, and if there's anything concerning features or review systems positive for giant cell arteritis, get ESR, CRP, CBC. And then if I'm concerned about compressive optic neuropathy, I'm ordering an MRI. All right. Can normal tension glaucoma be related to low corneal hysteresis? Yeah, so low corneal hysteresis is kind of a surrogate marker of kind of shock absorption of the optic nerve. And so low corneal hysteresis is a pretty well documented risk factor for primary open angle glaucoma. So I don't know that much about particularly its role in diagnosis and management of normal tension glaucoma, but since normal tension glaucoma is kind of an offshoot of primary open angle glaucoma, I would think that low corneal hysteresis would be a risk factor for normal tension glaucoma. So kind of doing some extrapolation there. So what if a patient has 17 millimeters of mercury pressure and central corneal thickness of 440? That's a really thin cornea. Yeah, so if the central corneal thickness is 440, that's very thin. Pressure 17, that's pretty underestimated. I probably consider that primary open angle glaucoma. But yeah, why were alpha agonists avoided in collaborative normal tension glaucoma study? Great question. I think it was thought that that would affect optic nerve head perfusion. However, but then there was a follow-up study comparing brimonidine, which is alpha agonist, and timolol, which found that actually, as we discussed already, brimonidine had neuroprotective features and preserved that visual field better than timolol at statistically like comparable pressures. And so I think it was thought that it would be affecting the optic nerve head perfusion. What are side effects of rapacidil in low tension glaucoma? So rapacidil is a ROCK inhibitor. In the United States, we have nitacertil or Repressa. So side effects I've seen not really related to low tension glaucoma specifically, but across the board, you can get conjunctival hyperemia, subconjunctival hemorrhages, and occasionally you can get a very impressive kind of bolus corneal epitheliopathy, which can result in high pressure. So I see those across the board in my use of ROCK inhibitors. What is the effect of lowering IOP below episcleral venous pressure in glaucoma in general? So you sometimes want therapeutic, very low pressures, especially in the management of low tension glaucoma. And so you can run the risk of hypotony, and different eyes have, in my observation, different thresholds for what is clinically significant hypotony. One person's 8 may be visually fine, and one person's 8 may be clinically hypotenuse. So the effect is, well, you can get to your target pressure, but then you do run the risk of hypotony. What is the role of color vision tests in this diagnosis? Well, if you have reduction of color plates, that then, you can have, that may be concerning for more of a compressive etiology as opposed to glaucomatous optic neuropathy. I don't routinely check color plates in these kind of new glaucoma patients, but if I'm concerned there's something concerning or questionable in the history, things aren't lining up, there's optic nerve pallor out of proportion to disc cupping, then I would recommend checking color plates. For thin corneas from refractive surgery in glaucoma, how should we determine the IOP target or correctly estimate the IOP? Yeah, I mean, it's challenging when there's not, correctable like tables. Again, the central cornea is this thickness, therefore the pressure is this. So I just get a gestalt. Okay, well, it's a thin cornea, therefore the pressure is going to be underestimated. So the way that I determine pressure target, I mean, is the patient more likely to have primary open angle glaucoma or normal tension glaucoma? So if in doubt, I just shoot for a lower pressure target, 30% reduction from, baseline. And so there's a lot of gray areas, we just don't know everything. And so if in doubt, I just go more aggressive pressure lowering target. Let's see. Do you believe that some beta blockers don't have vasoconstrictive effect? They would have called intrinsic sympath, Sympathomimetic effect. I don't really know how to answer that question. I'll, to be honest, I'll write it down and look into it. Beta blockers, yeah, vasoconstrictive effect. Yeah, I'll look into that. And I can't promise I know all the answers to these questions, but yeah, I'll have to review actually, because probably brush up on my basic science knowledge would be always helpful for management of these patients. So I'll look into that and I'll make note of your name. So, all right. I like being stumped. Okay. What is your opinion of smartwatch blood pressure monitoring the management of low tension glaucoma? I don't, so I guess smartwatch, like one of those Apple watches, blood pressure monitoring, I think especially if, say, there's concern for progression at pretty low pressures. If I'm seeing patients progress in low tension glaucoma, pressures 10 to 12, maybe we're wanting to avoid a blood forming procedure or they've already had one. Well, then I'm like, okay, well, let's monitor your blood pressure. I think a smartwatch or device like that can be extremely helpful in getting a range of blood pressure throughout the day, particularly late nighttime blood pressures, which, kind of nocturnal hypotension then runs a risk of optic nerve head hypoperfusion. So I think it'd be very useful. Yeah, I'd recommend it. Do you perform an MRI as part of the diagnosis? Oh, sorry, back to that question. There was a follow-up question. What blood pressure goal should I have my patient attain? Well, that's a good question. I'm not really treating high blood pressure, low blood pressure. I'd be working with a primary care doctor on that. But, according to that big study that was performed in, regarding hypertension management, many patients are shooting for pretty low blood pressures. And so, if in doubt, if I'm concerned that maybe they're getting some nocturnal hypoperfusion of their optic nerve head, then I'm having them keep a log. And I'm curious, I get a little bit concerned about patients with systolic getting close to 90 or below and diastolic 50 or below. I mean, that's very arbitrary. It's just, what kind of puts my antennae up. And if we're getting those on their logs, then I'm maybe picking up the phone and calling the primary care doctor or cardiologist being like, hey, I'm a little bit worried about that affecting the optic nerve health. And so I think that, as glaucoma management experts here, we're really, maybe some of us are kind of data freaks. It's interesting to get more data on things so we have more to work with. And a good blood pressure log can give me really valuable information as to whether or not I need to pick up the phone and say, hey, do we need to make some adjustments here? And so I don't have a blood pressure target, and that's a kind of very patient specific depending on their comorbidities. But I do like a log, because if I see any of those diastolic, systolic looking pretty low, then I may be working with their primary care doctor and cardiologist on optimizing that. Okay, so long-winded answer. So do you perform an MRI as part of the diagnosis process? Only if I'm concerned about compressive optic neuropathy. And that's typically in patients where there's a mismatch between optic nerve appearance and nerve fiber layer scan and visual fields, and especially if they have neurological symptoms. Dose for ginkgo biloba. Well, I don't routinely recommend it. So, I mean, patients sometimes find the information on their own and say, hey, what do you think about this? I'm like, well, there's some data that suggests X, Y, Z. I don't routinely recommend it because in the United States, we don't have FDA regulation of supplements. And so you can get varying amounts of doses depending on what company you're buying that supplement from. And so that's something you probably would want to look up and see what other glaucoma specialists recommend, but I don't routinely recommend it. Okay. So I see a question in Spanish, and so I have some amount of Spanish knowledge. So low tension glaucoma is basically, the way it's defined is glaucomatous optic neuropathy that is occurring at statistically normal pressures. And so normal pressure, I say 10 to 21 range. So glaucomatous optic neuropathy, that's occurring in that range. But you can also have progression at, low teens, 10 to 12 range. Is there a role for SLT in low tension glaucoma? Yes, there is. We reviewed that in the lecture. You can't get as impressive a response in low tension glaucoma because you're starting from baseline pressures that are in the normal range. But yeah, you can get a modest effect. I believe one study found about 15% reduction from baseline. Do you believe that dorzolamide can induce local vasodilation in the optic nerve by increasing PCO2? I don't know enough about the biochemistry of topical carbonic anhydrase inhibitors with regards to its effect on PCO2. So I'll have to skip that question and look it up. So thank you for stumping me. So yeah, I'm getting a question here about eye drops like brimonidine causing conjunctivitis after about 6 months of use. Red eye, I kind of hate brimonidine. It's obviously got great neuroprotective features in low tension glaucoma management, but I see this effect with brimonidine all the time where patients can get follicular conjunctivitis and allergies. And so if they're developing a sensitivity like that, I would just discontinue it. Yeah, and someone commented probably getting a preservative-free drop. That can help too. Yeah, so based on your experience, do you evaluate the normal tension glaucoma prognosis compared to open angle hypertension glaucoma? Okay. So yeah, I think I'm trying to understand what question you're answering here. So I think these normal tension glaucoma and low tension glaucoma patients are a little bit trickier to manage than primary open angle glaucoma because they're starting from normal pressure. And so, you need to aggressive pressure lowering. Many times these patients sometimes these patients need surgery earlier than primary open angle glaucoma management. And so, and in many of these patients, I'm looking at like systemic issues, as we've discussed, blood pressure and the like. And so they're more nuanced, require a little bit more history collection and share time than primary open angle glaucoma in my experience. And so they may need closer follow-up. So it's a little bit less straightforward than the management of primary open angle glaucoma in my experience. We talked about corneal hysteresis and low tension glaucoma. Is a pressure of 5 millimeters mercury too low for any glaucoma patient? That depends entirely on the patient. I've had some patients with, pressure of numeric hypotony 5 or below who do fine. They don't have any signs of hypotony, such as corneal epithelial folds, macular folds, etc. But I have other patients with signs of hypotony at statistically normal pressures 10 to 12. And so pressure goal and whether or not patients are tolerating hypotony is very patient specific. Do you regularly look into medications for hypertension to rule out hypotension, nocturnal hypotension, and ask for modification of systemic prescriptions? I think that's a great question. And yes, especially in patients with low tension glaucoma, I'm inquiring, I'm like, hey, are you being treated for hypertension? If so, what time of day are you taking your blood pressure medicines? I ask that question of all my low tension glaucoma patients. So yeah, I do ask it, especially if they're on systemic beta blockers. And another comment mentions carbonic calcium channel blockers. So good. So is diurnal variation of IOP part of the workup for normal tension glaucoma? Well, I consider diurnal variation of IOP in all my glaucoma patients, especially, if I'm seeing a new patient for the first time in the afternoon. Pressure tends to peak early morning and go down throughout the day. And so I think about that in all of my patients. And so if I'm seeing a normal tension glaucoma patient who I think has normal tension glaucoma patient for the first time in the afternoon, I'm like, I wonder, why don't we have you come back 8 o'clock next appointment, see if maybe their pressure is actually in the high range. So maybe it's more POAG. And so I do think about diurnal variation of pressure in all my glaucoma patients. Yeah, so how do we differentiate POAG patients from low tension glaucoma patients treated with systemic beta blockers? So that's a great question. Yeah, so I'd have to look at to see how much of a pressure lowering effect, intraocular pressure lowering effect we're getting from systemic beta blockers. I don't, if you're seeing a patient with that you're concerned has low tension glaucoma in the low teens, pressure in the low teens, and they're on a metoprolol or what have you, and they've got the classic features, disc hemorrhage, paracentral scotoma. Well, I think I would just have to look at the whole clinical picture and say, okay, classically it's showing signs of low tension glaucoma as opposed to more bread and butter open angle glaucoma. So it can be nuanced, and it's not a really straightforward answer, but you have to look at the whole clinical feature. Do they have, classic vertical cupping, or is there a notch? Do they have a nasal step, arcuate or paracentral scotoma? So you have to look at everything. What is your experience with metastatic and low tension glaucoma? I don't, off the top of my head, I can't think, I don't know. I think generally the way I use nitastrudel is like refractory topical treatment, usually buying time before surgery because it's quite cost prohibitive for most of my patients. And so, and then one of the studies I reviewed, it's been shown to potentially enhance, vascularity of the optic nerve head, but because of at least the way things are priced here in the United States, it's rather cost prohibitive. So it's usually refractory treatment topically. So what clinical drop treatment do you recommend to reduce 30%? Yeah, good question. So 30% pressure reduction goal is pretty aggressive. And so many times you can't get there with just one drop alone. And so, if I'm starting initial treatment, unless I'm really concerned, typically I start with one drop first, or, if I'm starting medications, rather, I start with one. So I'll start with bromonidine or latanoprost, and then, have them come back 6 to 8 weeks for a pressure check, and then watch testing closely. So it's hard to get that 30% IOP reduction with one drop alone. So yeah, to answer your question, I've not seen, bromonidine have that effect alone, 30% reduction, but maybe prostaglandin analog, as the next one commenter said. So sometimes a combination of those two can be helpful. All right, so we talked about when to do imaging when you're highly concerned about central nervous system process, neurological symptoms, mismatch of clinical appearance, some pallor out of proportion to cupping, testing doesn't match up, neurological symptoms, I'd get an MRI. Let's see. Have you seen low pressure glaucoma association with IFIS or tamsulosin use? I haven't. I have not. It's interesting. I'll think about that, but I'm not aware of an association with tamsulosin and low tension glaucoma. So what I like is when other people answer other people's questions. So one person asked, can we define low tension glaucoma in one sentence? And the answer, which one of y'all put, which I agree with, is glaucomatous optic neuropathy occurring within a statistically normal pressure. I agree. That's great. Thank you. Okay. What is your threshold to send patient to primary care doctor for anemia or coagulopathy workup? And if they're found to have either, does this change your management? I mean, so many times I'm not typically the one to diagnose, say, anemia, unless, so usually they come in reporting a history of anemia, like iron deficiency anemia on iron infusions or whatnot, or known history of coagulopathy. And so I'm not typically the one sending the patient to the primary care doctor requesting a workup. Typically the patient comes to me aware of these comorbidities already. And so, but that said, if I'm, know this patient has low tension glaucoma, they've got pretty good pressures, there's evidence of progression despite pretty good pressure control, well, then I'm going to think about blood pressure monitoring, maybe rule out anemia, coagulopathy, et cetera. And so does it affect my management? Well, we're treating the pressure goal aggressively, so not really like the ophthalmology management, but maybe it affects my counseling in the sense that, okay, well, I'm working with, this is a team taking care of you, not just the ophthalmologist. Okay. So is there any association of low tension glaucoma with keratoconus in advanced stage? I'm not aware of that association between low tension glaucoma and keratoconus. Yeah, so again, love it when you guys are answering each other's questions. Is optic nerve head hemorrhage common in low tension glaucoma? Yeah, classically, you get disc hemorrhages. So yeah, what is your first line glaucoma medication in normal tension glaucoma? Someone answered this already. I think bromonidine is a great choice. If the patient's been on it before, or if you try that and it's failed or allergic, then I would try latanoprost next. Is normal tension glaucoma a diagnosis of exclusion? No, I don't think so. As with, you have to, yeah, so you be concerned, have your antennae go up if you're seeing on exam or history any red flags. And we've talked about that before, limited diet, exposure history, sexually transmitted disease history, review of systems concerning with many neurological symptoms or some neurological symptoms, giant cell arteritis, review of systems positive. So I'm having those in my mind if there's some kind of mismatch in what I'm seeing on testing. Again, it would be minimal cupping, but there's dyspallor, testing isn't lining up. So yeah, I would actually, I'm not saying normal tension glaucoma is a diagnosis of exclusion, but do think about other potential causes of optic neuropathy if there's a mismatch in your exam and history. What can you do for hypotension if a patient's not on any hypertensive medicine? So that's a great question. That a little bit beyond my pay grade, but so yeah, you can get for patients, and I think this may be related to that Flommer syndrome, which is like a primary vascular dysregulation syndrome, classically seen in like tall, slender Caucasian women, highly myopic, blood pressure runs low. I think, I believe there's a few clinics in the United States that focus on like, these patients, but I've heard of, patients or some ophthalmologists, some glaucoma specialists recommending a very salty snack before bed to mitigate that risk of hypotension, nocturnal hypotension, and optic nerve head perfusion. Not a lot of evidence-based medicine on that I'm aware of, but it's something you could offer. And so if a patient's got hypotension typically, and that if they're not already seeing a primary care doctor or a cardiologist, I would probably link them up and just have good, close communication with them. Treatment available for vasospasm, I'm not sure because wouldn't prescribe that. So I don't want to speculate. What's your opinion about water drinking tests in patients with low tension glaucoma? I don't routinely recommend the water drinking test in the diagnosis of glaucoma. I think that's a little bit outdated and also a little bit cruel. And many of my patients have significant comorbidities, congestive heart failure, et cetera. So I wouldn't recommend that. Is diurnal variation related only to open angle glaucoma? No, I think as I've answered earlier, I keep that in mind for all of my glaucoma patients. And in the context of normal tension glaucoma, I think about that. If I'm evaluating a patient for the first time in the afternoon, I want to think, okay, well, maybe you come back in the morning next time to make sure I'm not missing an IOP spike that could maybe more align you with primary open angle glaucoma diagnosis and low tension glaucoma. We didn't really review ghost cell glaucoma in this, so I don't really know of, so I'm not gonna, so Rho kinase inhibitor are useful in ghost cell glaucoma. We didn't really cover that. I don't really know the answer to that question. All right. Would you consider lowering episcleral venous pressure with Rho kinase inhibitors to reduce IOP, considering that this may be the final hurdle? Yeah, I mean, again, the way that I use Rho kinase inhibitors is as a kind of last-ditch effort before surgery, namely because of the cost. And also, some of those side effects are not insignificant: conjunctival hyperemia, hemorrhages, especially hyperemia. I don't really, I guess, think about it as mechanism per se. I think about it as literally we're throwing the kitchen sink at you. And maybe I should think about it more in the mechanism standpoint, but this is the last topical agent we could try before we think about surgical procedures. And so, so I think about it in that way. All right, so we made it through all the questions. I want to thank you all. It's 8:10. Thank you for spending the morning or whatever time of day you are in the world with me. And I appreciate you taking the time to listen. Have a good day.